This is a 31-year-old woman who also had Roux-en-Y gastric bypass. You can see the enteric contrast that she was given kind of leads to this point here.
Internal hernia.
Yeah, where there's this hernia and this segment of bowel not looking happy, and all the distal bowel decompressed. So this is right at the JJ, which is where many of these tend to occur. This went to surgery, and they found a defect in the mesentery caused by the anastomosis, twisted around 2 rotations, and they were able to reduce it, but there was an area of bowel that had necrosis, and so that was resected. But just, we see a lot of these Roux-en-Y patients here, and this is one of the complications. So,
can we tell if it's anticolic or retrocolic, the rheum?
this one,
I was reading that when they did the anticolic, it reduced the rate of like internal hernias that were occurring through the mesenteric defect.
Yes. Yes. Yes.
This one, if you go up, I think it's anticolic. Sorry, I think it's retrocolic.
Oh, okay, so it's old school.
This one is retrocolic. This one was done in 2012.
But interestingly, usually the internal hernia is it herniating up through the transverse mesocolon, and then the bowel loops would be located more superiorly, I think.
So this one looks like a paraduodenal or something like that.
Here are 3 slides on internal hernias from bariatric surgery. You can see the defects here. And this first one, as they classified here in the surgery journal, it's mesocolic one where you get a cluster of bowel in the left upper quadrant. And then the second kind is, it's a mesenteric one where you have cluster of small bowel pressed against the anterior abdominal wall of chronic mesenteric vessels. And then this less common one, Peterson hernia, which is this one here, where it's anterior to the pancreas and posterior to the colon. So here's this bowel loop here that is herniated through. I think this one would be classified as mesenteric at the opening of the JJ. All right, questions?
I have a comment. Even though I have a high index of suspicion for internal hernias, I seldom have high level of confidence.
These are always very difficult cases. I think we just kind of have to raise the suspicion, and that's typically what happens here. Many of the people who read our ER cases are not abdominal trained, but they are trained to tell that something is abnormal, and there's actually a very low threshold for the ER doctors and the surgeons to take these, especially these patients who have had Roux-en-Y gastric bypass, to a laparoscopy. And we are also kind of trained to have a low threshold for suggesting that something may be abnormal. This is for the abnormal, but sometimes it's not so clear cut. This next case